Okay, my other assignment was to interpret Mrs. Massey's ECG. Before I start, I just wanted to quickly just briefly talk about what an ECG is and what exactly it's measuring. So ECG, you have these different electrodes, different leads placed in different parts of the body, explained really well on my handout. I don't want to go too much into it because last time, this is the second time I'm recording this, and the first time I went on to over 15 minutes. So I'm going to skip a lot of stuff which are already on the paper. But it measures the change in the depolarization and repolarization changes through the heart wall that can be felt on the skin. So it's placed in different parts of the body, and these depolarization waves are seen on the ECG paper. So, for example, when the beginning of the heart cycle, the atria, it depolarizes, which is known as the P wave, which precedes atrial contraction. Okay, and then the wave of depolarization would move down from the SA node down to the AV node, down through the bundle of His in the Purkinje system, and move back up. So as waves of depolarization moves toward a positive electrode, okay, then it's going to have a positive deflection, meaning it's going to go above the isoelectric line. And if it moves away from a positive electrode, it's going to have a negative deflection, meaning it's going to go the waves that you see on the ECG, and there's one on my paper. A sample of a normal ECG, it'll go below the isoelectric line if it's moving away from a positive electrode. So the P wave is the first wave you should see before you see a QRS wave. The P wave is atrial depolarization, QRS is ventricular depolarization, and the depolarization always precedes actual contraction. Okay, and then the T wave is the ventricular repolarization. Repolarization of the atria is masked by the QRS wave. Okay, and then you have segments. Okay, and these segments are important in evaluating whether the ECG is normal or not, because it should happen in a set interval. So you have the PR interval, which is between the P wave and the R wave of the QRS complex, and the PR interval should be between 0.12 to 0.20 seconds. Now each box, Mrs. Massey's ECG is not very clear. The lines are not very clear because normally you count the seconds. You can count the duration by the number of the boxes. Each small box is 0.04 seconds, each small box, and 5 boxes make up they group together for a faster reading of the ECG, and each 5 boxes is 0.2 seconds. Okay, so the PR interval should be between 0.1 to 0.2. Mrs. Massey's, it was hard to read Mrs. Massey's because Mrs. Massey does not have a P wave. Her leads 1, 2, and 3, which I'll get to in a minute, does not have a P wave, so it was hard to read what the PR interval is. But I think I found one, and hers seems to be it's hard for me to show you this, but on lead 3, where the waves are inverted, you can maybe predict that one of the waves is a P wave that precedes the first R complex, and that seems to be shorter, just about one space, which is 0.04. So that seems to be a little shorter, but I couldn't find any research that shows what a smaller PR interval meant. A larger PR interval would indicate some kind of heart block, meaning it's taking quite a long time for the wave of depolarization to come from the atrium, make its way down to the bundle of His and Purkinje to depolarize the whole ventricle. So that can indicate some myocardial problems, some heart blocks. Okay. So several things you should look at when you're reading an ECG. You should look at the rhythm, okay, and look at the P wave, inspect the P wave, QRS waves, and all that. And also check the heart rate. You check from one R wave to another. And in Mrs. Massey's, I counted it, her heart rate seems to be about 75. And how you do that, we were taught in the first semester that you can do a quick and dirty way of checking the heart rate is you look at 1 R wave. I don't know if you can see this, but you look at 1 R wave, and you count each line on the box. This is really hard to show you because her lines are not very clear, but each line would indicate, for each line you divide 300 by 1 for the first line, and the second line 300 by 2, 300 by 3. So when you're counting, it'll be 300, 150, 75, and so on. Hers seems to fill 3 boxes, 3 lines, so it'll be her ECG, her heart rate is about 75, which is normal. Okay, so before I get to all of Mrs. Massey's reading, I just wanted to show you this, which I included in my paper. It tells you what, when you're looking at the ECG, what normal should be when you look at it. For leads 1 and 2, and for leads 1 and 2, QRS should be net positive, okay, and for AVR it should be net negative. When I say net positive means it should go above the isoelectric line. If you look at this, it's going above the isoelectric line, so it's net positive. The QRS waves falls above, okay. In the AVR is normally net negative, and you see that these deflections are below the isoelectric point, electric line. AVL and AVF should be net positive, okay, and the QRS, this is for the QRS wave, for V1 should be net negative, and V5, V6 should be net positive. Mostly, I was reading, you mainly look at the leads 1 through 3, they're the easiest to read, and they're what we focused on. Leads 1 and 2 should always be net positive, okay. In Mrs. Massey's, they actually are, lead 1 is net positive, but lead 2 is net negative. And another thing you'll notice about Mrs. Massey's ECG is that there are no P waves, okay. And I don't know if you can see this, I've written all over it, but you can see that there's no P wave preceding the QRS waves. And this normally means that the ventricles are depolarizing before the atrium, or before the atria contracts. So they're depolarizing independent of the atria. So meaning their signal is coming from below the AV node, okay? And this means there are several things. I was reading that when you don't see a P wave, it could mean something called junctional escape. And the cause of this junctional escape could include the SA node ischemia. It could mean increased parasympathetic tone. It could mean hypoxia or some kind of electrical imbalance, heart failure, cardiomyopathies, and myocarditis. Mrs. Massey also had an S3 sound heard, which can be normal in children or very skinny people, but otherwise it's pathological, and it could mean that when the atrium opens and diastole starts and the ventricular filling starts, there is some fibrosis of the myocardial wall, of the ventricle wall, and so when it hits, it makes a large sound, an S3 sound, which normally isn't heard except in some few exceptions. Okay, so I am leaning towards her having some myocardial problems, either some cardiomyopathy or heart failure. Okay, and in the interest of time, how long has it been? Oh, it's already 9 minutes. I will stop there, but I'll just conclude by saying that Mrs. Massey's ECG is definitely not normal. Her lead 2 is net negative, which it should be, as we in my paper you'll see a sample normal ECG. It should be net positive. Okay, her lead 1 is net positive, although you have you can't see a P wave in either one of them. So there are some problems. It's hard for me to read the PR and PR interval, but I could read the RR. Her heart rate is normal. So junctional escape, due to the several reasons that I've explained, seems to be the problem, and due to her S3 sound, I'm leading towards some cardiomyopathies. In my paper also, I just wanted to point out that I went through in the index section the things you should look at when reading an ECG. You should look at the rhythm, the heart rate, the intervals, the P wave abnormalities. For example, if the P wave is too anyway, I won't get into that because it's not, it doesn't relate to this case, but you can look at the P wave, you can look at the QRS abnormalities, which we talked about, and look at different ST segments. There are no ST, that's one thing I wanted to add, no ST segment elevation or depression, so we can rule some of the problems that might indicate. Thank you.